without further ado, let me introduce very, very briefly Janindra, so maximise the time that he's got to speak and then to address Q&A. Janindra, massive supporter of Redline Group. He's our patron, and we're very proud to have him as a patron. Aside from that, he is, of course, an eminent and extremely talented colorectal surgeon, consultant at St Mark's Hospital, and he's really taken on the mantle, I think, of being the foremost colorectal surgeon dealing with pouches in the UK, if not Europe, if not the world. I'm delighted to have him here tonight. Many of you will know him from very personal experience, of course, but I'm really looking forward to hearing his pearls of wisdom and having the opportunity for Q&A. Thanks very much, Janindra.
Thank you, David, and thank you everyone for inviting me yet again. And it's of course a great honor, as always, to be a part of the Red Lion Group and support as best I can. I'm not entirely sure if David's introduction does me justice, but I'll do my best. Thank you very much. So I think Gary and I had a bit of a conversation before about what I talk about, and I feel like I spend a lot of time talking about minimally invasive pouches and do we do robots or this or that or the other thing. But I think the real concept here is a lot of it is about decision making, how we sort of come to how people come to their decisions about where they go after a colectomy, particularly in ulcerative colitis, which is the sort of common reason for wanting a pouch. And I thought I'll also run through some of the conversations that I have with people and some of the questions I'm asked, and then leave it up to all of you to ask me um, what it is. So I'm going to start my introduction. I think when I started at St. Mark's back in 2010, we had quite a few patients who used to come and see us. We having a conversation about wanting a J pouch. But actually, we've noticed over the years, and particularly after COVID time, those numbers have started to reduce quite significantly. Even the numbers of pouches that I do per year has reduced compared to what I used to do pre-COVID time. And there are a lot of speculative reasons why I think so, but just before I go into them, I think we did a study a few years ago looking at the differences between those people who had their colon removed for ulcerative colitis and then moved on to have a restorative procedure like a pouch, and we compared the data in the UK and compared the data with Sweden. And about 50% of people in Sweden will go from having their colon removed to then having a pouch or some sort of what we call a restorative procedure, meaning you lose your stoma. Um, uh, and in the UK, that number is about 30%. And I would suspect that those numbers are even a lot lower now than the 30%. Now, why do we think that is the case? I think uh, one of the big problems I think is that for the longest time there was no control in the UK as to who does them and what you think a minimum number is acceptable for a surgeon or a center to actually perform this type of surgery. That has changed a little bit recently, and now the Association of Coloproctology will say that you, as a surgeon, you need to do a minimum of five cases, which per year, and that doesn't seem like a lot, but that is sort of what was accepted. And I think the big problem we noticed, and when we looked at a lot of the data of the volumes of what people do and what are the outcomes, we know that the less you do, the outcomes are bad. So once you start to get a few problems, then people start to discourage you, as surgeons say, well, it has a lot of problems, so on and so forth. And so I think that's one of the things. So that there is a reluctance to refer people to the tertiary institutes that actually do the pouches, and it's much easier just to discourage people than have the conversation. And I think the second thing I feel is that social media, and this is my personal view rather than anything based on data, but I think social media has changed the way people look at things as well. A lot of the stigma that goes against having the stoma that was present in the past is now not as present, and people are not afraid to be a lot more demonstrative about uh, having a pouch, and so on and so forth. So that whole social stigma and the uncomfortable nature of um, uh, having the stoma has sort of uh, is not as prevalent as it used to be, and I think that's because people are a lot more aware of it. So from my perspective, I think at the end of the day, what you want to have as an individual is very much an individual choice. And our jobs as clinicians is to give as much information as we have available to someone, about what we think their quality of life is going to be, and that will include lots of things like what you have to eat afterwards, what do you, how can you, how does your social life work? When does your bowels start working? How many times a day do you think we would go? And is there going to be any leakage afterwards? What are the complications of the procedure? If the complications happens, how is it going to manifest itself? So it's actually quite a lengthy, by the time we go through the whole process, which includes myself as a surgeon plus our pouch nurses, who have the conversation with the patients. We're talking about an hour and a half long conversation in the first instance, with the ability to have further discussions down the line. So I think the way I describe it to people is that it's very much a quality of life operation. It's an operation that an individual chooses because they want something in their quality of life. They don't like the idea of having a permanent stoma, or a permanent stoma itself has its stigmas and sometimes issues as well. So I think that having a very comprehensive discussion, in my opinion, is always a good thing. And even if one has made a decision that a stoma is the way they want to go, I think it's very worthwhile actually having that discussion, because you feel like you've got all of the information and you're making the decision for the right reasons. So I think my job as a clinician is never to push someone in one direction or the other. My job as a clinician is to um, um, make sure that I have given the information, and an individual makes the right choice that they feel is right for you. And one example that I often give is your employment, and what you do is also important. So, for example, if you're a long distance truck driver and you spend 12 hours plus on the road, and it's not always easy to find a toilet, a pouch may not always be the best option for you if you suddenly need to um, stop in the middle of the road but not be able to find a toilet. So I think those are all important things that one needs to consider in making the decision. Um, we've talked a lot about the surgical side of it. And I think that probably my highlight is that you shouldn't be afraid if you're making a decision about any sort of surgery to ask your surgeon how many of those operations you do, what is the experience you have, because at the end of the day, that it shouldn't be driven by us as the clinicians. It should be driven by you. Have to feel comfortable with the individual that's doing your surgery, because at the end of the day, it is your quality of life that you're dealing with, and it is essentially an individual's life that we're dealing with it, and so one that goes horribly wrong. Not to say that it doesn't go horribly wrong in someone with a lot of experience as well, but the chance of it happening is much less. So I think that that's sort of, if you like, my very brief way of uh, trying to put the skeleton of how the process goes in the decision making for an individual, and how the discussions go. And I'm very open to having any discussion you want from here, and leave it open season.
That's fantastic. Thank you very much indeed, Janindra. And you've given us a great deal of opportunity here to drill into some detail and ask some questions. So this is a great opportunity, everybody. So again, if you wanted to ask a question of Janindra, then please feel free to type in the chat. Or I can't actually see everybody because there's so many of you on the call. I can't actually see on one screen. So um, perhaps, Gary, could you keep an eye out if people have got their hands up?
Got someone who's got their hand up, Peter?
Yeah. Right. Thank you, everybody. I actually asked this question to David recently on a personal message. Do you think the social media puts people off actually having a pouch? I obviously am on the J Pouch forum, and I've noticed there's a trend that there's quite a few people that are sort of coming in that really quite negative views about people having problems, and they're all coming in putting the three penn'orth in. And I just wonder, I mean, I don't know how much of the social media you actually see, Janindra, but to me, it just seems a little bit negative. I mean, I've had my pouch 25 years, and I say, I mean, for me personally, it was the best thing that ever happened. I had an absolute torrid time with my stomas. I had actually three because they were remade twice, and then I had a temporary stoma, which was not really very happy to deal with. So when I got my J pouch, I was determined that I was going to jolly well do my best to keep it. And that's probably one of the reasons why I've experimented with J pouch, with Medina catheters and irrigation and all the rest. I was one of the first ones that would have publicising the fact that you can irrigate. And my surgeon, which was Nigel Scott, I don't know if you may remember, he was a colorectal president, I think, of the society. He said, well, if it works for you, that's fine. And that was the attitude back 25 years ago. Now, of course, we've got a lot more information. And I think the stigma, like you say, even the stigma of stomas, as I say, has gone. But at the same time, there seems to be a lot of sort of misconception that we don't have the experienced team. The one we had at Salford, where I had my surgery, is no longer in existence. And even at Salford, at the MRI in Manchester, I was in basically for an emergency situation, and the stoma nurses there didn't really know much about J pouches, which was a bit surprising. I ended up having to teach the ICU nurses how to intubate a J pouch. So there seems to be a little bit of a black hole of information in certain parts of the country, and I wonder whether that is putting people off. I mean, it's maybe it's an open question for other people to ask, but I certainly raised it with David. But I'd be interested to see what your views are.
So I think you're right, and I think that I the one of the problems is so that there are a number of ways of looking at it, as I guess, and I don't have I don't have a definite answer to the question, but my feeling is, and I don't go through a lot of social media, so I can't tell you what I see on a regular basis, except for conversations I have with patients. But one of the things I find interesting is that when people have a problem and there is no way of actually going to find a solution or trying to talk to someone who might help with the solution, then that becomes a problem. And the easiest way is to try and find other people with a similar problem, right? And so you find that with most conditions now, and that's how sort of forums come about. And there are positives and negatives to that. So I don't want to put the fact that you have a forum as something really wrong, because it gives people an idea, if you like, of what happens if things go potentially wrong. The problem is to do with how much balance there is in those forums. And when the balance is a little bit one side or the other, that's when the whole thing is, and it's very, very difficult to balance it out, you know. That's what I think, in a very, very sort of pragmatic way of looking at it. So, but then that's where us as clinicians have a responsibility to see how we can balance it out. Now, eventually, I think you form your opinions depending on who you're comfortable with. But it's not about trying to say, okay, that's wrong, they're wrong. That's not correct, because whoever is mentioning it is right for themselves. It's more about trying to see what the percentages are and how people do it. And one of the classic things that Professor Northover once told me is people make their decisions are sometimes a little bit like whether your general mentality is that of a gambler or an insurer. Someone who's insurer will take very little risk, whereas someone who's gambling will say a 70% risk of success, 30% failure. I'm not quoting real figures, but I just put it out there. Is okay for some people, but it's too much for others. So how we deal with that uh, is also important. And I think it's about trying. So my I feel that my responsibility is not to put down the social media, because I think it creates good conversation. My responsibility is to see whether I can help balance it out.
That's really great. Thank you. Kerry, you had your hand up first of all. Is your comment about this topic?
Yeah, I was just interested. No, it's about just the pouch in general, because I'm considering I've had a stoma since May, and my
Yeah.
surgeon suggested the pouch. My concern is the risk of urgency and leakage. What sort of percentage risk is that? Because obviously, when I had colitis, that was how I had to live my life for a very long time, and my stoma, touch wood, has actually been working quite well for me. And obviously, I've read quite a lot about the risk of if with the pouch you have urgency again, leakage. So I'm just kind of weighing that up in terms of quality of life compared to living with my stoma that I seem to be working okay with at the moment.
Mm. I think it's a tough question, and again, this is where the whole comes about. I mean, most people, if the pouch is done properly and there's a little bit of the rectum left behind, there's a tiny bit, very rarely have leakage. Occasionally might have some at night, but perhaps not to the same frequency as you do with colitis. But then if it a little bit, I mean, there are a few factors that come into being. Again, like I said, it's a long conversation, so I'm going to really shorten it down. But you have to think about things like, would that little bit of rectum get inflamed? That's what we call cophitis, but all of those are manageable, and a lot of the what we do is there's a whole education process that goes with our pouch nurses afterwards to try and minimize all of that. And that's really important, in terms of how you manage your urge resistance and so on and so forth, so that you can go through that process.
Mm.
Thank you.
Gary, you had your hand up.
Yes, I did. I was just going to echo what Janindra actually said regarding social media and our Facebook J-Pouch support group, for example. I think by their nature, they tend to attract people with problems. So therefore, you tend to see more negative comments than positive comments on social media, which can give a distorted view as to what living with a pouch is about, because there's probably 90% of people that have pouches don't actually join support groups or Facebook groups. They just get on with their lives. I think we've said this before.
Yeah.
Let me ask you a quick question that's come in, I think, from Colin. A lot of people presumably don't get the chance for a pouch, even to consider a pouch.
Yeah.
As the number of centres doing pouches shrinks in the UK and it's concentrated in excellent centres, presumably there's an awful lot of people being referred to secondary care who don't get the opportunity to even think about a pouch. They would be given a stoma straight away.
Yeah, and I think that's essentially what happens, and I think that's the sad part of the whole thing, because I do get people who've had the colon removed, rectum left inside, and then they'll come 5-10 years later to say, I sort of never was allowed that conversation because my surgeon said it was a waste of time.
Mm.
I don't think anything's a waste of time if you're going to have a discussion, and then the decision becomes to the individual based on the information provided. So I think I don't know, if you ask me, I think it's a basic human right to have that decision, and then the discussion, and then after that you can make any decision that you feel is right to you as an individual.
Yeah.
I was going to say, if I can jump in, is it the case though that in some centres people wouldn't even be given the option to subsequently have a pouch, because at the time they have the colectomy, they would remove the rectum and close that option forever?
Yeah, it does happen, but most people have the rectum there present and only removed if there is a problem. That's my understanding, but I don't have the figures to prove that.
Yeah, if I can come up with something else actually, because I kind of have empathy with, I think it was Kerry who is in the situation that she's getting on very well with a stoma after having suffered with colitis.
Yeah.
Which was a situation I was in many, many years ago, when the plan had been that I was going to have a pouch after about 6 months of the first surgery. And I found myself getting on so well with the stoma, having suffered with colitis for so long, that I delayed and delayed and delayed until effectively I was put in a position where I was going to have surgery one way or the other, because at the time they were saying you either have the pouch or we will remove what we left in with the rectum. I don't know if that is the case anymore, but
that's exactly the case that I'm in. Yeah.
So I think,
So at that stage, my feeling was, well, what have I got to lose in having the pouch? If it doesn't work out, I can go back to having a stoma. And as things transpired, it worked out very well, and I had 30 plus years with the most fantastic pouch imaginable. I didn't belong to any Facebook groups or anything for all that time. But then, as you know, it went wrong at the end. After 30 years, it started to have problems with strictures and blockages, and I'm back with a stoma now after all that time, and actually glad I made that decision as well. But my question is, I've learned now that it isn't a case of what have you got to lose when you're making the decision at the beginning, because it seems to be that if you try for a pouch that doesn't work out and you go back to having a stoma, the stoma is not necessarily going to be as good as the one that you had initially for reasons that you can probably explain better than me. So, and that wasn't explained to me at the time I made that decision nearly 40 years ago.
Yeah. Oh, that is something I always make a point, because I don't think that it's correct to tell someone, oh, well, you will always go back to you can always go back to a stoma, because exactly as you said, you're already losing about 30, 40 centimeters of your small bowel. So the stoma is a little bit more higher output. It's not always easy to bring out a nicely shaped stoma, so you can have issues with leakage and so on and so forth. So it's not always what you think it is. So that there is a certain element of wanting to make the decision. And so in sort of people who come and see me in Kerry's situation, I usually say, take your time to make the decision. You don't, there is no rush. The only thing I would say is, if you leave your rectum inside every year, have someone peep through it with a telescope, just to avoid the cancer risk in the long run. And I always say to people, you know what the NHS is like. Someone gets missed down the line, so take control of making sure that that happens, because you don't want to come in a situation, find that you haven't been surveyed for the last 5 years, and then suddenly there's a cancer or something. So we try and avoid those preventable things. But otherwise, I think it's a very much a take your time, because remembering that one way of looking at it is, if you've had a long period of colitis and you've been quite unwell, and that in its own right has affected your quality of life, and then suddenly the colon gets removed and you feel really good. You feel like you have more energy. You feel like you're not constantly waiting for the toilet. Your hospital admissions are virtually non-existent compared to before, and so on and so forth. You're not on any medications anymore. Fatigue becomes less of a problem. So there are so many positives that suddenly come in, because you dip down to this point when you have colitis and suddenly you shoot up very quickly. So there's a period where you might want to enjoy your life. But then there are others who absolutely hate the fact that they have a stoma and want something done very quickly. So everyone has a different way of looking at it.
Thank you very much. Howard, you've had your hand up for a while.
Can you hear me?
Yes. Yeah.
Lovely.
There
Hi,
you go.
Janindra. I'm one of these peculiar people, as David knows I am anyway. I had UC for 40 years and had the old flare up, took steroids, everything fine. I once went 20 years without a flare up until I got rid of it. Anyway, I had a pouch which failed after a year. So I had a stoma. I've got them both now, of course. And I just want to make a couple of bullish comments. Firstly, I agree with what's been said. The publicity is increased in leaps and bounds, because I had the stoma 15 years ago. So I've watched in the last several years things improving in virtually every respect. The only big problem I have is finding the disabled loos. When I go to a football match or something like this, and I've emailed my favourite club about this sort of thing. So things are better. I've never found that I've had a problem with any aspect of life. The thing you mentioned just now about being tired, yes, that's the only debit side, but then I'm getting older, so perhaps that's part of it. I have one of your wonderful dietitians, and I try to keep care of myself, and I live, as far as I'm concerned, a normal life. So I want to say that to people. I know we're all individuals. Everybody has a different experience. As you know, I've been chair of the IBD panel for many, many years. I've relinquished that, by the way, to give other people a chance, but I'm still involved with the health and improving things for patients and carers. So that's my take on things. I don't know what you think about, for instance, the manufacturers. I know we're talking about pouches, David, but about things like the bags, because everything's improved. I went to a thing, an event last week, which was jam-packed out. I noticed Peter Day is here. He was at it. And things are really good. And I don't want to say things are hunky-dory everywhere, but really, if people have these things, there's advice, there's experience. The IBG and Stoma nurse fraternity, if I can put it like that, is improved. I think your previous comments about getting the right sort of staff. Tell us if it's not too sensitive a subject about where you get, because we see staff, patients, particularly without a complaint, don't always see the same consultant, don't always see the same nurse, and they get used to an affinity. So I've thrown an awful lot at you. I'm sorry about that, David, but I just wanted to put the other side of the coin, because my experience, I know they're all different, you know, we all have different attitudes to it all, but really, I can't think of anything that I can't do that I did before. There we are. Leave it at that.
Thank you, Howard. Thank you. Good balance.
No, and I think that's essentially the balance of the whole thing. You know, you different people, but I also find that when you live what is a normal life for an individual, you don't have much time to spend on social media and other things because you're too busy doing everything else.
I'm not on social media. I abhor it. So maybe that's a good thing.
Yeah. But I think you're right. I mean, in terms of I mean, I think you all know that we had a bit of a dip in our pouch service, for example, recently, because of a few changes in the staff, and we've sort of gradually built it back up again. And when you have those sort of dips in a service, that has a massive after effect for people as well. You know, where do you go when you're in trouble? Who do you reach out to? And all those services taken away. And I think those are some of the things in that the financial and administrative side of the NHS don't always see some of the things we do from behind the scenes to actually reassure and support people, you know. And that's why even groups like this are very important, because as you well know, when there was when the crisis came, you all reached out to me, and we did our best to see how we can support the community as best we can. And I think we have a responsibility as clinicians to do that. And that's why I think communications like this and having patient group and clinician association is very important, because we're all in one team, you know. It's not a you versus me sort of thing. We have to be in one team, and we have to function together for everyone's benefit.
Mike, you've had your hand up for a while.
Yes, hello team. Hope you're all right. I was lucky enough to have Janindra as my surgeon. I'm trying to work the date out, and I think it was 2017, and I'm hoping he recognises the Scouse accent as the Liverpool copper who came down to have his surgery done. And probably reiterating what Gary and Howard have said, in that I was doing all the research, you know, trying to work out, is it best for a pouch? Should I have a stoma? At the time I was playing rugby. You could probably tell I'm a serving police officer. Continued to play rugby with my stoma, continued to be operational with my stoma. Kind of had a decision to make as my wife fell pregnant with our second child, and I think the dates around me decision making for a J pouch were coinciding with the birth of me second daughter, and I decided on the pouch, and what a decision, you know, touch wood. I mean, we've all had a few blockages, I assume, the pouches who are on the line. my guilty pleasure was a steak. And, sometimes you don't chew. And despite Zara drilling it into you when you're in St. Mark's, you must chew your food. You just end up plowing down, don't you? I'm probably like what Gary said. After my surgery for my stoma, you've had UC for a couple of years, and the pleasure of not sitting on the toilet, 20 times a day because I had my bag was great. But the decision to then go to a pouch, I think, was also a very good one. The only research I've been trying to do is what's the statistic behind people who've gone for a pouch going back to stomas. But again, everyone's different. So although there will be data on there, and I'm sure there's such and such percentage of pouches, I don't want to say fail, but may not work for people. You end up going back to a stoma. That's probably the fear. I think if people are sat there with stomas who are considering the pouch, I'm probably sitting there with a good quality of life with the stoma and thinking, do I really want to go down the route of surgery again? Do you want to go down surgery to then, potentially have issues? They're probably in the back of their mind are thinking, well, what if the pouch doesn't work? I'm going to end up back with a stoma with, as Janindra says, 30 to 40 centimeters less of my bowel. So it means I'm going I'm having more movements and things. So that would be my only question. I really wanted to dial on just to say hello to Janindra because what a guy. And I really appreciate all his work. And it was literally fate. I'm sure no one will mind me sharing that I was in Wiston Hospital up in Knowsley in Liverpool, and my original surgeon unfortunately fell ill, and little Louis Vittoni came up to cover his appointments, and it was Louis who seduced me with St. Mark's as one of the best bowel surgery places that was in the UK. And then I met Janindra, and the rest is history, as they say. So, but yeah, that'd be my only question to probably reassure people who've got stomas who are considering a pouch. Is there a failure? I say failure. Is there a rate of which that stomas return back, J pouches return back to stomas? And that'd be my only question, really. If I had my face again, it's because I've got a job on.
Thank
you, Mike. And
thank you.
Really nice to see you. It's been such a long time, so I'm pleased to see you doing well. Because one of the big things is that when people do well, I don't see them very often, or if at all any. So it's really nice to see from this forum and know that you're doing well. In order to answer your question, I think when we have the discussions, we say about 10% of people will have a pouch that doesn't work, and exactly as you said, Mike, it will be it can be for a number of different reasons. It could be that it's affecting their work. It could be that you have things like pouchitis. It could be that there is a long-standing chronic problem that we can't fix in any other way. But so it's on average roughly about 10% of people, and most will do okay. But it can also be over a long period of time.
I was given a number many, many years ago when I had my pouch surgery, which in the early days, and there wasn't any long-term history or much long-term history. But somebody, in fact, I think it was Prof. Nichols, said that they estimate that 5% will fail after 5 years, and 10% after 10 years, and 20% after 20 years, etc. So as they get older, but at that time there weren't really pouches 20 years old around, whereas now there are quite a lot of long-term pouches. In fact, we've got some members on Red Line Group that have had their pouches over 40 years and still going strong. Yeah. So it's very individual.
I mean, what we're trying to do is trying to work out well in advance, to see whether there are risk factors, and we haven't really been able to pinpoint any that would say yes, your pouch will is at a higher risk of not working, because it's also that concept of not working is different for everyone else. So I think, I mean, as Gary says, I mean, the first pouch was done 1978, I think, 78, 79, somewhere there. And so we don't have that that many, and that you have to keep in mind that those early pouches were very much it was a procedure done on experiment, and we've sort of come now a long way based on how to do it. The concept of keyhole surgery, how we deal with leaks very early on, and there are a few other things to try and improve outcomes in pouches. So I think we've still got a whole lot of stuff in another 20 years to look to see how we can improve it. I think the big ones are, the difficult ones are if there is a change from ulcerative colitis to Crohn's. And the way we explain that to people is that when you have inflammatory bowel disease, it's more like a spectrum of disease rather than you have ulcerative on this side and Crohn's on that side. You can have a flip because it's no different to having arthritis when you have ulcerative colitis, for example, because it's an autoimmune disease at the end of the day. So those things can happen, and those are the unpredictable parts of it because you can't often predict that those patients will get those problems.
If I can pick up on that, that's a really important point. I think we're gonna come on to talk about later pouch failures, but there's still, I think, some questions around, certainly in the chat about patient choices and which choices they should make, and that's really, really difficult because it depends on individual circumstances, obviously. But we'll come back to that. But on the topic of pouch failures, I read a great paper, looked like a really good paper. I was trying to find it just now, I couldn't find it. And it was a meta-analysis. So a meta-analysis is across lots and lots of different studies, where similar questions are being asked. So you can take the data from all these different studies and kind of blend it together to increase the statistical power of the outcomes and make more certain your statements. And so this was a meta-analysis of over 23,000 people who had pouches due to ulcerative colitis. So this is a massive, a really massive study. And the failure rate is what they were looking at, amongst other things. And the failure rate in the first 5 years was 6%. And the failure rate in the first 10 years was 9%. And it didn't go up much beyond that. But they didn't go very far beyond that. So the old figures that I had quoted, 10, 11, 12%, maybe higher, maybe a little bit high. And that's the first point I wanted to make. I don't know if you're familiar with the paper. It looked pretty good. I mean, I don't have
Yeah.
it. The other thing that I wanted to just comment on is in the 2017 pouch survey, which was a really decent bit of work, mainly UK centres, many centres. It looked at, I think, 5,000 pouch grey chin episodes, and the outcomes for patients was one of the consequences. And it also looked at what were the success factors, key success factors. And it came up with two conclusions, I remember. One was that there was a whole bunch of surgeons doing 1 or 2 procedures in 5 years, and that they didn't necessarily have a body of expertise or experience to conduct the operations as good as someone who was doing lots more operations. So experience was important in terms of patient outcomes. And you're seeing this concentration of expertise, I guess, in these centres of excellence that ACP GBI are accrediting, which is really good, really great. And I know that there's been that sort of condensation, if I can call it, of pouch surgery into fewer centres. The second one was Crohn's, misdiagnosis of ulcerative colitis when in fact the person has either indeterminate colitis or Crohn's. And that seems to me that was the biggest, I think, risk factor. And one thing I'm sort of I heard your comment about Crohn's there. Has the diagnosis of ulcerative colitis versus Crohn's got any better in the last, I don't know, the last few couple of decades, such that you can say with more confidence that the outcomes are likely to be better or worse with pouch surgery now because the status with regard to the inflammatory disease is better defined?
So the short answer to your question is no, because I think the problem is that, like I said, it's a spectrum, right? So even though we can look back on the pathology of a person who then develops symptoms very similar to Crohn's, for argument's sake, and say, well, let's look back and have a look and see whether we missed the diagnosis. Was there anything to suggest? And you see, it looks like ulcerative colitis is the answer. So that I think that's where the problem comes about, is that that there is a reasonable chance that what we think is that there is a evolution of some form. It's the same argument for pouchitis. I don't think to this day we understand why giving bacteria works for pouchitis. And secondly, now, when
Antibiotics.
giving antibiotics work for pouchitis and without a bacterial contact, and then we sort of know, we have good evidence now. There is a good study to say that if your antibiotic resistance in the presence of pouchitis, and your pouchitis doesn't respond to antibiotics, then going back to the biologics seem to work for people with pouchitis as well. So that's sort of something we look at a little bit more in detail as well.
Okay, so if I understand that correctly, the risks haven't really changed in
That's
recent
correct.
years. So when it's still the same sort of risks.
Yeah.
Okay, that's, and presumably no sign of any breakthroughs in terms of, well, because of the evolution, you can't predict it. So that's difficult, I guess.
Yeah.
Okay.
I think the breakthroughs are coming in trying to manage it a little bit better, particularly now that we can use biologics for people with pouchitis that don't respond to antibiotics.
Yeah. Great point. I mean, the biologics have probably, well, a couple of people we've heard from anecdotally, but also on webinars, have said that biologics probably have, I think you said it as well, have forced down the number of operations that are happening per se, because there's less inflammation. That's great, Peter. You've had your hand up for a little while.
Right, there we are, unmuted. Right, on that topic, I'm just a bit of history again. When I've been basically using a Medina catheter and irrigating from day one, and that's over 25 years. During that time, I've never had pouchitis. Whether that's a fluke on my part, or maybe it's because I think that's kept my pouch reasonably healthy. Now, it's not something that was particularly mainstream then. I mean, I learnt about using a Medina catheter from a publication by the John Radcliffe. I think it was Neil Morrison mentioned it in one of his articles. And over the years, I have mentioned it time after time after time on forums, and mentioned it to people that I've come across in seminars. And most of the time, people have just said, "Oh, you do that? Oh, why?" This sort of thing. Nowadays, through obviously people at St. Mark's, it's become mainstream, but I don't think it's universal. And I wonder sometimes the number of people that have lost pouches, that if had a chance to actually try that system. We're now getting new systems that come through, like the Aquaflush system. I was just spoken to a gentleman that's actually trying to do a research into an improvement for the Medina catheter, and he's asked me to take part in the clinical trials for that. So there are opportunities there, but unfortunately, it doesn't seem to be that the information has spread through the medical community. Because as I say, my friends at the MRI, who were looking after me when I had COVID, they were quite surprised about what I did and why I did it. And they were their stoma nurses that were supposed to be looking after pouch patients. So there's clearly a black hole of communication within the medical profession as the best way sometimes to treat these things. And that's from my experience over 25 years. And I know it's better now, but I still think there's out there is that lack of, ways and means to manage pouches that aren't, that are a little bit troublesome. I mean, obviously, we've got the standard way of using metronidazole and ciproxin. I personally am allergic to ciproxin. I mean, there's rifampicin, which I think is another one, but it's so expensive that very few doctors are actually willing to give you that. There doesn't seem to be a lot of research onto these issues because presumably the number base that you can do it is small. So it's a problem, and I think it really needs sorting, and hopefully St Mark's being one of the places it's got the most patients available to do that on would be a good place to start.
So I think that goes back to my conversation about volume, because we only learn as clinicians when we have patients, when we have a large volume of people with the issues. So then we can, because it's a two-way street again. It's about understanding what people are going through and then trying to see what the solutions are. And then bit by bit, we all gather our knowledge together and outcome the solutions. So I think that's one of the importance of having a high volume center with a support group. And I make no excuses for the fact that I'm heavily reliant on the pouch nurses to support me to give out the best outcomes for people who come to see me, and I cannot do without them. I cannot do without them, because they're very knowledgeable, and it's an important thing, because sometimes there are conversations between surgeons and patients, and the pouch nurses and patients are different, and we have to listen to what they say to different people, and then try and blend it all in together. And I think that is important as well.
But let me ask the general question, if I may, Janindra. There's a couple of questions alluding to this. Well, not alluding to it, asking it. There's immediate post-operative challenges while people are recovering from the surgery. Maybe it's just what you come across on the chats and in the forums, but Gary's experience of a late pouch failure doesn't appear to be unusual. And Maria's had a pouch for a while that's been dysfunctioned. We've got comments in the chat from people who are also facing problems after a long time with a pouch. And Gary makes the point. I mean, I know Gary very well, and he had a fabulous functioning pouch for many, many years, decades, and then had a failure. And there's a couple of questions around when you're consenting people. Well, first of all, is there evidence that late stage pouch failures are increasing, or is that real, or is that just anecdotal? And is it more a case that we don't know what happens because, of course, not many people have 40-year-old pouches? So
can I say something first?
Go on, Gary.
Well, it wasn't like a sudden failure. It was gradual, and it started off with problems with emptying, and then I started to develop problems with strictures and blockages. And I was told this is a consequence of scar tissue strictures, potentially from the original surgery some 30 years ago. I think as we age, our bodies change. They change shape, and maybe that's a reason why after, just like other parts of me start to fail after you turn to my age, then, the pouch goes along with that. But it doesn't apply to everybody. As we've said, we've got people with older pouches on our group. But as David says, there does seem to be a pattern of people with long-term pouches that get to a certain age and they deteriorate. Mine I probably could have lived with it for longer in its deterioration if I hadn't had that complication of having the fistula, which really forced our hand. I might still have it now, but the period of deterioration over the last maybe 5 to 10 years gives food to thought as to whether you should continue with the pouch or go back to the stoma. Anyway, back to Janindra.
Yeah, I mean, I think you're right, Guy, and I think there are lots of different reasons sort of for that whole late failure, as we call it. And I think, some of it is even if you have a full colon, your bowel habit sort of changes as time goes on. Your ability to tolerate foods in some people changes as well. We sort of get people who complain a lot about bloating and all of those. We sort of brand them all as irritable bowel, for argument's sake. And then of course there is the whole concept of, is there an element of how do the adhesions play into it? And now that we do most of our pouches laparoscopically, is that going to change the whole adhesion related issues going into the future? Because it's much easier to go back in if you have to, if things have been done by keyhole. And so I think in order to sort of um, answer your question, I don't think we have a straight answer to that, because again, it varies from individual to individual as to why you choose not to have your pouch anymore.
Is there low level inflammation over many years that causes adhesions and strictures?
Honestly, I don't know. It's a good question, but I don't know the answer. I make the assumption that there shouldn't be any inflammation, but why do people have, by argument sake, you should develop your adhesions not long after your operation? Why does it go 30 years before it causes a problem? I honestly don't know the answer to that.
Yeah, yeah. I mean, it's interesting, isn't it?
Yeah.
Whether we're prone, people who've had ulcerative colitis in the past, whether we're prone to low level inflammation, or indeed whether the comment that was made earlier about flushing with a catheter to completely empty the pouch, whether that reduces the risk of inflammation. We don't know, do we? Let me, a very quick, really good question just come up. I'll just ask it because I think it's a fairly quick one to answer. If you are referred to a secondary care centre and you're offered a pouch surgery, does that mean that the hospital is one of the accredited centres? Or are there
No.
No.
The short answer is it's not always the case. I think you're well within your rights to ask.
Yeah. Okay, thank you very much. Kerry, you've got your hand up.
Yeah, sorry, it's just hopefully one quick question. Obviously, I'm reading quite a lot about the negatives of the pouch, which isn't always the good thing to do. But what's the benefits of the pouch over the stoma? Is it literally that you don't have a stoma for life?
Yes.
It's just one.
Yeah.
So all these kind of risks that come with the pouch is weighed up against just what I think is quite old now, the stigma of a stoma, potentially.
Yeah, but I think for different people, I mean, there are reasons why they don't like their stomas as well, because if you're constantly, I mean, stomas are not without their problems. So I think it's fundamentally wrong to say that having a stoma means that there's no complications associated with it. You can have
stoma for the moment then.
Yeah.
I've just been lucky so far.
No, that's, again, you just like the pouches, you'll have about 10%, 15% of people who have trouble with stomas. Either the bags don't fit properly, some people have allergies to the bag. There are various, the different level of spectrums, but there are problems as well. So it's, if you will find that there are pros and cons, and I think that's the point of this. It's about having those discussions, and I find that a lot of people like yourself who feel very comfortable with their stoma will sort of hang on to it for a bit longer while they get through life and make their decisions for whatever reason. And that's I think what I really like to highlight is this is about individuals, not about a right or wrong answer, because it's a
Yeah.
quality of life operation. And
Yeah.
and if your stoma works well for you and your quality of life is great and it doesn't affect your body image, or there are various different reasons why people don't like it, then that's great.
And so if you have because the second consideration is having the rectum removed without the pouch. If you have that done, is the option of a pouch gone forever?
Yeah. So once your rectum's permanently removed, that's it. That's
Right. Okay.
permanent. And that's why I always have that discussion with people, say, if you haven't made up your choice, then if you haven't made up your mind or made a decision, then hang on to it, but make sure your rectum is surveyed, because you don't want to miss something and say, I
Yeah.
was waiting for another 5 years or something
Yeah,
like
no,
that.
my surgeon has mentioned that if I keep my rectum for the time being, I need to be checked every year. Thank
And
you.
I think that, I mean, in the old days, they used to say there was an age limit to which where you could have a pouch, but I think there are certain factors we look at, especially in the female population. Have you had any complex vaginal deliveries? Is there any damage to the sphincters? Those sort of things need to be considered. But I mean, I very proudly have a picture to use in my office of someone who was 68 when I first, in 2010, one of the first pouches I did, who sent me that because she was very happy with her pouch. So it's horses for courses is probably
Yeah,
the best way of putting it.
thank you.
Fabulous, absolutely fabulous. Another quick question, which might be fairly straightforward to answer, so I'll deliver it ahead of others. People who are taking time, as you recommended early on, to consider which surgical option they're going to choose. So they have their stoma and their temporary stoma whilst they're making their mind up. Does the risk of failure, is there any consequence for how long you leave that decision in terms of the long-term health of a pouch if you choose that
No, I don't think so.
route? So you can
Yeah.
take as long as you want. Yeah.
Yeah.
Okay.
As long as you survey, and I make that point all the time because that
Mm,
is the most important thing to
mm,
say.
mm. Okay. Let me ask you a quick question about probiotics. Do you now you just have to bear in mind, folks, Janindra is the surgeon, and probiotics would generally, I guess, be dealt with by the nursing team or dietitians post surgery. But do you have a personal view about probiotics and where it
So,
sits in terms of
yeah.
pouch care?
So I don't think that anybody's actually looked into I don't think that anybody's actually looked into uh, taking probiotics as a prophylactic thing to prevent. The only really evidence we have was the VSL-3 study, which is very much a long time ago.
Yeah.
But then, we take, especially with people with irritable bowel and so on and so forth, we do take things like some people, we prescribe things like Synpro for argument's sake, which seems to work very well for particularly bloating and all of those. So I don't have a strong view, but I don't argue, I don't argue against um, trying it because it's not going to harm.
Hmm.
But like other things, it might make it worse in some people, and then you stop it, or it'll make it better. Because it's the same argument that, in a different sense, with the fecal transplantation, for people with pouchitis, and we did that, and that doesn't work
Doesn't
particularly
work. No. All right.
either. So I think there is more to what causes all these problems than we quite understand.
Yeah. Yeah. I mean, it's indicated, it was indicated before the government stopped reimbursing it, prescriptions,
Yeah.
only for the 2 weeks after you've finished a course of antibiotic treatment. That's
Yeah.
what it was indicated for. So there was no data to support or a license for prophylactic use
No.
regularly. But I mean, I still take it just because I think it's a good thing. But and many other people do. But the only evidence is based upon after you've had a course of antibiotics for pouchitis, a 2 week course of VSL or what's the other one, Viva Mix, to help restore healthy bacteria in the gut. I still don't understand it. I still don't get healthy versus bad bacteria.
No.
Still don't the differentiation that it, an antibiotic is that clever to weed out the bad stuff. But I guess there's must be some science behind it. I'm going to ask a few questions about GLP-1 in a minute. But before we do that, there was a topic that came up. A couple of people talked about it. It was about iron treatment. I don't know if this is your area really, but I'm going to ask it anyway on behalf of the people who've tabled it. Ferrous fumarate. Would you expect ferrous fumarate to irritate pouches? If so, could it also irritate the esophagus and nose? This person's currently taking 2 tablets per day to try and replenish their iron store.
So the short answer is I don't know, but I think what happens is that we do have some people who say ever since I took my iron tablets, it irritates the pouch. So again, there's no evidence, but I go on what I hear. And under those circumstances, we sometimes send them for iron infusions. So yes,
Right.
it can irritate some people, and
Yeah.
I don't think it's exclusive to pouches.
I think we've heard from a couple of people that the tablets have the same problem as in that it's not absorbed very well in us in pouches. So the infusions seem to work a lot better because it's directly into the blood.
Yeah.
Yeah. Okay. Right. So can I ask you about GLP-1s?
You can, but I have no straight answer about that because I honestly don't know.
So
Because we don't have a lot of experience with GLP-1s in people with pouches.
are you doing any research or thinking about any research in GLP-1s in pouches?
Not at the moment, because I think the thing about GLP-1 is it's become like quite the fad in terms of people losing weight. How that affects your pouch, I honestly don't know. And I'm not sure that outside of collecting data and people who have used it and seeing what happens over a period of time, it's not something that I don't think we can sort of start a research that says, oh, let's just give a few people GLP-1 and see what happens. Because I don't think that would be ethically correct.
We are getting, I know it's anecdotal, but we are getting some remarkable testimonies, albeit personal testimonies. For everyone's knowledge, in case you haven't guessed, the GLP-1s are the Monjaro and the other one that is for people who are pre-diabetic and diabetic, I think. And it also has the side effect that it really helps you with weight loss. And there's been a number of people posting when the themes come up on the Facebook group with quite staggering outcomes, but not just weight loss, but also comments about an anti-inflammatory effect of the drugs and other benefits, other health benefits, but certainly reduced frequency. So that's it reduces motility, doesn't it? So
Yeah, I mean there is I mean they're slightly different, but there is a similar sort of class of drug that they use for the intestinal failure patients to reduce their requirement of parenteral nutrition. I think it works on slowing the whole system down. So I can see the logic behind it, but whether we can prescribe it for that reason, well, the short answer is right now, no. Um, but it is something that we sort of, just like you, I'm starting to hear it.
Yeah. Yeah.
And
Yeah.
it's one of those things. But I guess it boils down to, why do you have the frequency in the first place? Is it because of the way your gut is? I mean, if you look at certain people who have a stoma, their stoma can be constantly high output watery.
Yeah.
Or,
Yeah.
and you have a rough idea. I'm starting to learn a little bit that how your stoma functions is roughly how your pouch will function. If your stoma
Okay.
is
So it's a
really
good
active,
predictor. Yeah.
it's this is again very anecdotal on my part, but I'm starting to sort of understand from talking to people. But our guts are very interesting things, and how they react to. I mean, the best way of putting it is your gut is one of it is the biggest antigen processing units
Yeah.
that you have in your body, so that
Yeah.
every single foreign body in some way or form will go through your gut.
Yeah. Yeah. I still don't understand that. We lose a massive organ that's involved in acquired immunicity or whatever.
Yeah.
It's massive in terms of our acquired whatever the word is, and yet we don't seem to have a problem with acquired immunity.
Mm-hmm.
So we've lost this fabulous thing that does this wonderful stuff for people with large intestines, but we don't seem to suffer from it. I don't understand that. And
I
even
know,
else
but
for
I think
heart
that's
disease.
because the small intestine takes it over. But
Right.
I think the small intestine is the major place for
Okay.
the
Okay. So that
immunogenicity.
happens there.
That's why, yeah.
Yeah. Okay. We've got a question from a fabulous gentleman from France, all the way in from France. This is very off topic, so bear with me. But as he admits himself, he's using a material, a Convatec material, as a plug or a cork against stool leaks. This is probably at night, I guess, or maybe it's not at night, maybe during the day as well. We've heard quite a bit about plugs. Ellie Bradshaw, when she was at the hospital, gave a couple of great webinars. And if everyone's thinking about this, particularly, she was talking about nighttime leaks, using a plug as an anal plug as a solution for nighttime leaks. Do you have much experience of that? And the gentleman's asking the question about, do you have an opinion on it generally?
So the plugs we had previously had a lot of issues because they wouldn't stay like a cork.
Yeah.
And exactly as is said in the chat, they would go inside, and yes, they would come out, but that would be a problem because it never really functioned, and there were one or two we had to remove.
Yeah.
Under an anesthetic or by endoscopy or so on and so forth, because they wouldn't come out.
Yeah. Yeah.
But
But
I
that's
think the
the exception.
principle,
Yeah.
I think the principle is correct. In that if you're getting a little bit of leakage and you have a cork that works well and that you can hold, I think it is a good principle. Because I think in most circumstances, the actual leakage that you get is a sort of very thin leakage, and that's usually because you're woken up by the fact that there is leakage, and people are very aware of it. I think that's the way it works. I mean, people who experience it would know it better than I do. But at the same time, I think the best way of putting it is, yes, that whole ability to cork it has its advantages, but we still don't have the best technology. So I'm very obviously I'm always very interested to learn from these things, because we don't always um, aware of it.
Yeah, that's a great answer. I think oh no, there's a great couple of videos from Ellie Bradshaw that deal in detail with plugs. I think also Zara used to talk about seepage as opposed to leakage.
Yeah.
Seepage is insidious because people don't necessarily know it's happening, but it can be very, very difficult in terms of causing butt burn. So
Yeah.
this is where you don't realize it's happening. You get a tiny leak, really doesn't affect you very much, but all the time that you're walking around and doing stuff with a small bit of fecal matter close to your skin around your bum, of course, there's a potential that it'll be irritating and causing butt
Yeah.
burn. So that's a really important consideration. I'm gonna call this last question because it's almost 9 o'clock. You've been incredibly patient and incredibly good to answer all these questions, but I think you're still in your fatigues, aren't you?
Yes.
Are you still in the hospital?
Yes.
Goodness me. My goodness me. I'm sorry, I didn't realize that until I was
No,
just
no, don't
here
worry. It's
thinking,
fine. It's fine.
yeah, that's a very fashionable shirt he's wearing. So all right, let's ask this one question about bleeding. Is stress still a risk factor for people with pouches in terms of causing inflammation and bleeding? Um,
I, I think it's not just for pouches. I think stress causes problems with the gut full stop. And
yeah,
that's what I would say. It's probably more prominent, or you feel it a little bit more in the pouch because you don't have your colon.
yeah.
But I think we're starting to understand, and that's why we have an amazing uh, we have an amazing gut psychology unit, the psychological medicine unit here at St. Mark's, which we rely heavily on to sort of support people through their various journeys of trying to balance it out. So it's not necessarily to say just because you have some gut issue that you need to see a psychiatrist, but it's about getting your psychology in the right place, and it's more than just a stress of having the disease. It's also how everything else affects you as
I,
well.
I
So I
mean,
think it's really good. I mean, I'm a great fan of putting people through hypnotherapy, for argument's sake. I mean,
mm,
I believe you have to believe it, but I think there is a lot of complementary stuff that can help us through our journey when we're in a very stressed out situation. Because my best way of putting it is, some people get a headache when they're very stressed, and some people can get anal pain, they can get diarrhea. Any
yeah,
of those things can happen.
yeah,
And the same will go for the pouch.
yeah. That's really, really interesting. It's a really interesting thought. Just very briefly, Professor Inspector, he headed up
Yeah.
the psychology unit. He gave a talk many years ago to us. It was a really interesting talk. He
Mm.
talked about the way in which people process stress,
Yeah.
being an important factor in their gut health and other manifestations of stress. And he made the comment generally, it was a very general comment that people with problems like ulcerative colitis tended to internalize their stress rather than externalize their stress.
Yeah.
But anyway, that's an aside. I know there's a couple more questions coming in, but I am very conscious of the fact that Janindra needs to get home and say hello to his wife and probably eat something. So I'm gonna draw it to a close. It's 9 o'clock now, so I hope you don't have too far to get home.
No, 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 it's no problem.
No problem. Well, look, let me just say on behalf of everybody here, a massive thank you to you. You've obviously come straight from work. You're still at work, and it really, really helps this community to be able to talk to you and your colleagues about different aspects of the pouch and pouch life. And it really is a fabulous opportunity to touch base with you and with your colleagues. And so, thank you on behalf of everybody who's joined up tonight. Thank you on behalf of everybody who'll download this as a recording. One of the great strengths for Red Line Group is we have it all on film. Gustavo,
Thank you.
yeah.
Thank you everyone for having me. It's always a pleasure. But I thought this time rather than use slides that we should have a discussion. So I hope that was useful.
Absolutely fantastic. Thank you. I think I think everyone who's had the chance to ask questions and listen to the answers, I think has really benefited from tonight. So thank you very much indeed. And I mean, Janindra, it's worth mentioning you are very, very cognizant of the patient perspective. You're extremely, what's the word, patient friendly, if I can say that. And there's a great double act, I think, that's worth highlighting here with Janindra and Ben Barbanel, who I think was on this call earlier. I don't know if he still is, but it's really well worth a watch. The pair of them really work well together from a surgeon side and from a patient side, and it's really indicative of Janindra's attitude and why we're so delighted to have him as a patron of the charity. He's always there for us, and thank you so much for tonight, and thank you for all you do for Pouchies and for people with problems. Thank you.
Oh, it's a pleasure. Thank you so much. And thank you for having me. Have a good evening, guys.
Thank you,
Thank you.
Janindra.
Yeah.
Take care.
Bye bye. Bye bye. Bye bye all.
Bye.
Bye-bye.